This is a demonstration of a surgical cricothyrotomy. To start with, we're going to assemble our equipment. I have a bag valve mask device, and I have it connected already to an oxygen regulator ready to go there. I have all of my equipment for the procedure. That's going to include a disinfectant, a way to prep the site, a scalpel, I have a tracheal hook, I have an introducer device, a gum bougie, I have an ET tube. And in this case, I'm going to lubricate the ET tube. In an actual patient, there's usually a lot of blood involved with this procedure. There may not be a need for lubrication, but with our 3D plastic printed model, plastic on latex or plastic on plastic can be a little sticky, so we'll use it for that. The other thing I'm going to do in preparation is I'm going to preload my introducer in my ET tubes. This is not a required step, but it saves a step in the process, which is also very helpful. I also need to make sure I have a syringe so that I'll be prepared to inflate my cuff once I've got my procedure and I'm testing my cuff to make sure that it holds air. Now that I have that ready to go, I'm also going to confirm that I have a stethoscope for auscultating the lungs, that I have a capnography device for assessing Untitled, and I'm going to go ahead and pre-connect that to my BVM so it's ready to go before we even get the procedure done. At the point that I'm ready to prep my patient, obviously I'm wearing appropriate PPE, and now I'm going to prep the site. I am going to locate the cryothyroid membrane. You notice that I'm positioned on my non-dominant side of the patient. So in other words, the patient is to my left. That allows me to stabilize things with my left hand and perform the actual incision with my right since I'm right-handed. So I'm going to prep the area, clean it thoroughly, locate my landmarks, and then I'm going to use my scalpel. I'm going to expose the blade of the scalpel. In this case, it's a safety scalpel. I'm going to confirm my placement, and I'm going to puncture the trachea transversely. You'll feel a pop as you go through, and I'm actually going to cut until I reach the edge of that cartilage structure, turn the blade, and go back the other way to make sure that I have a big enough opening for my ET tube. At this point, I'm going to leave the blade in. I'm going to grab my tracheal hook, and I'm going to slide the hook alongside the blade, turn it 90 degrees, and then apply traction. This allows me to keep that opening in place as I move the scalpel out of the way, and I'm protecting the sharp scalpel or disposing of it in a sharps container. I can now introduce my gum bougie, and so the bougie can go in and slide, and it will go until it reaches a reasonable depth or until it strikes the carina and doesn't advance easily further, at which point you can stop. At this point, you remove the hook. It's important to remove the hook because that sharp hook will puncture the balloon on your ET tube if that cuff is still, or if it's still in place as the cuff goes by. Then we advance the ET tube, and I typically advance until the black mark goes past my opening, and that should be deep enough to be in an appropriate location. I can then remove the bougie. I can inflate the cuff with an appropriate amount of air, typically 5 to 10 milliliters, and now it's fairly secure in place and I can go ahead and ventilate, but I still want to hang on to this and make sure that I don't lose control of its location. I'm going to ventilate my patient, and I'm going to assess. I'm going to watch for chest rise. I'm going to hook up to capnography and look for evidence of exchange. I'm also going to auscultate bilaterally, and as soon as I'm convinced that I have the appropriate placement, I'm also going to secure this. If this is an ET tube that was designed specifically for this procedure, it will have tabs and a securing system with it. If not, I can simply use tape. I'll have my partner ventilate the patient while I secure this in place. And it doesn't need to be an elaborate tape job, but something that's going to hold the tube and go down securely to the patient so that it doesn't accidentally get dislodged. I'll continue to ventilate my patient appropriately, assessing for evidence of subcutaneous air, any difficulty with effective ventilation, continuing to suction oropharynx or suction blood away as needed, and also watch for any secretions or liquid in the tube. One alternative for doing the surgical cricothyrotomy is doing a transverse incision only, which is demonstrated on another video. Another alternative is what I'm demonstrating here, which is to do 2 separate incisions. And the reason for that is we have a lot of vasculature on the sides, the thyroid, and structures that can be damaged. So if we're doing a single transverse incision, it's possible that you could do damage to the structures on the side. So one more cautious approach is that you can, after prepping your site, and using your scalpel, find your landmarks, and you start by doing an incision vertically just through the skin only. We're not trying to go all the way through the membrane, we're just incising through the skin. Once we've cut through the skin, we can use our finger to palpate through the skin, feel down. Hard to do on this prop because the tape sticks, but you basically are opening up the skin and making sure that you found the appropriate landmarks. Once you know you're in the right mark, you make a puncture through the cricoid membrane, and just like with the transverse, we cut to one side until we reach the edge of the cartilage. We turn the blade and cut the other way till we've reached the edge of the cartilage. We now have an opening that will be large enough for our tube. I then use my tracheal hook to maintain that while I remove the scalpel and dispose of it appropriately. And now I'm able to introduce my bougie or introducer device. Once I've introduced that device far enough, I can remove the hook, and then I can go ahead and place my ET tube into place, and I'm ready to ventilate my patient.